Welcome back to Peer2Peer, the podcast, brought to you by Rayner. In this second part, Professor Graham Barrett continues his discussion with Professor Dan Reinstein and Mr. Darshak Patel on cataract and refractive surgery for patients who have undergone laser procedures. Keep listening as they shift the conversation to selecting the right IOL for this patient group and the benefits of RayOne EMV.
Let's backtrack a bit. I'm going to hopefully listen more to what you feed back to me, because I think your collective experience in refractive surgery certainly surpasses mine. But it is a fascinating topic. And I think all of us in our practice realize that the number of patients turning up for cataract surgery, either for presbyopia or because they've got cataracts, is increasing. And not a week goes by when even someone who doesn't have a refractive practice sees patients with a history of refractive surgery. Do you think every patient who's had a laser correction needs to have not just topography, but needs to have the amount of the Q factor or the aberration profiled and decision made on that basis? Because remember, I said for a low myope with a modern laser, I think you could probably go ahead with RayOne without doing those specific measurements. Or do you think everyone needs to have a proper corneal profile?
I mean, if you
measurement,
know what their refraction was pre-op, which some people don't know what their prescription was. They had LASIK 17 years ago, and they I don't know. I don't know, but I think you're right. But I mean, let's face it. We're in 2024. Unless you're doing a cataract camp in the Himalayas, honestly, you have a pentacam. I mean, you should. And frankly, you should have an MS-39 because it gives you the epithelial profile as well.
You can get the corneal wavefront on any topography device.
Now.
Yeah.
So anybody doing cataract surgery in the developed world, charging for it, who is not doing topography before cataract surgery is not delivering modern standard of care. It's just not. Some patients, they might have a completely decentered small optical zone PRK from 1995, and they're tolerating their coma. And then you do their cataract surgery and they're miserable because you've, totally changed what they got used to. I think we need to have topography in anyone having cataract surgery if they've had previous corneal refractive surgery. But I agree with you that you're not going to modify things most of the time. And
most of the time, yeah.
That the EMV, you're going to be able to put these lenses into the vast majority of patients.
It's also important because of rhetorics. I mean, it's a bit more nuanced, isn't it? If they've had previous laser, you're not just going to rely on the biometry. Does it correlate with the topography? Yes. So I think, and I personally would treat 0.75 and above. So when you're treating small amounts of astigmatism, you need to have the topography to correlate what you're seeing on the biometry, really.
So Darshak, I think we're on the same track. If you're having cataract surgery, you should have topography whether you had laser correction or not.
Yeah.
In 2024,
yeah,
basically. But then a lot of people do topography and look at the picture qualitatively. But what is the figure? Where do you derive the asphericity, the Q factor? Tell us what they need to be looking at.
Yeah, I mean, simply stated, look at the topography and make sure it's regular, because if you have inferior steepening or decentration, right there, you should be a little bit hesitant to just bang through without thinking about it. If everything looks relatively regular, you then go to the page where you have your wavefront analysis, whichever topography you have. Look at the spherical aberration, the Z4,0 or the C12, I think it is on some devices, and look at the coma. Now, the coma, hopefully, is given as one number at an angle, but if it isn't, then you're going to have to look at two comas, and that's like the X and the Y kind of thing, and then in your head work out. But those are the two numbers, right, Darshak? I mean,
yeah. There are obviously loads, but they're not the ones those are two most significant ones I would consider. Yeah.
all of the other, quadrifoil and heptafoil and all this stuff is not really relevant. So the brain is so good at filtering those little things at the top that spherical aberration is well filtered. Coma is less well filtered.
Yes.
But yeah, no, I think we should just demystify this thing. I'm gonna say one of the biggest improvements that I've seen in cataract surgery, post corneal refractive surgery, if you don't mind me saying, is your calculating formulas. Because going to the ASCRS website and looking at 15 formulas and trying to go, well, these three agree, that one's this, and well, which one would you pick? And then you call your grandma and say, which one would you pick? For us here, it's so simple.
Yeah.
We just use the True K and Bob's your uncle.
With TK.
Sorry, the TK.
True K with TK. Yeah.
Yeah, the TK, the total keratometry is what I mean. That's very confusing, by the way, but both of them are TK.
Yeah, terrible labeling, unfortunately, Darshak.
Back to surfaces of the cornea is,
Major facial cornea.
That one.
It's the best version of it. Yeah.
And it's just great. I mean, it's just great. It's like the blood pressure is normal, the pulse is the same. Bob, it's like, who cares whether it was post-refractive or not? It's the same.
I know.
So well done on that. And I know it's very complicated in there. I know it's not that simple what you did, but it's very.
Thanks, Dan. Don't forget to tell the patient how challenging it is and just take the credit when you get the good outcome. I think there's a change. Traditionally, you have LASIK and you have aberrations, and people say, don't dare add to them. But that's not what's happening out there. People are using, different lenses, and which, if you are going to do so, which lens could you consider? And I think RayOne is one. But of course, there's going to be some criteria. There's going to be some situations where perhaps not. But I'm looking to hear Dan's opinion and Darshak's opinion, because I suspect they've had more experience than me. I've been fairly conservative with post LASIK, although I ignore the idea that if they've had hyperopic, then you've got to put in a positive spherical aberration lens. I just don't think it's quite as cut and dried as that. And I think there is room probably. And Dan and Darshak, have you had experience with RayOne and post-refractive patients?
Well, the point that we make is that it's not, I mean, the answer is yes. But the point that we make is that the selection of the lens is based on the spherical aberration of the cornea. In other words, if you have adequate spherical aberration in the cornea, which we call spherical aberration in the therapeutic range,
okay. Mm-hmm.
then you can put in an aspheric lens that doesn't change the spherical aberration of the whole eye. If you've got a case where they had a very, very high myopic treatment on an old laser and they've got excessive spherical aberration, you can use the lens implant to reduce the very high positive spherical aberration, and vice versa. If you have coma in the cornea, well, we learned from the oculentis lens that a certain amount of coma actually works. Patients tolerate it, and it gives them the ability to see up close from that second image. So it's all about using what's in the cornea and modulating it with the lens that you're going to put in. So, what we're saying is that there isn't a generic way of saying, oh, post-refractive, you use this lens. It's not that way around. Yeah, that's the basics.
Yeah, I mean, I would agree with that 100%. I mean, I think that if you look at the cornea and it's been a low correction, and it's, flat but centered and not very blue, you can almost be certain that you could probably even use a RayOne without measuring. But anything untoward, like a big correction, an old correction, a decentered correction, you better measure it first if you're considering an implant which is going to add some positive spherical aberration. Darshak, so what do you have a threshold value for Z4, or, Dan's told us where to look.
Yeah.
What's the threshold value?
So in terms of
recommend?
the cornea, again, as we said earlier, 0.3 to 0.6, they're going to get a good depth of field from that. What's quite useful for us actually is because there are patients predominantly, and they've had presbyond in the past, we have historical measures of their depth of field anyway. Okay, they're phakic, so they'll have some accommodation, but what's their vision when you blur them back to plus 150? What's the distance corrected near vision? So we have, and also unaided near vision. So if I can look at a patient and I can say, yeah, they were 60, pretty advanced presbyopia, and they had all these measures showing me they had good depth of field, that's also a very strong indicator that I don't need to do anything fancy with the lens, because they're going to have all the depth of field on the cornea.
When you say anything fancy with the lens, you mean that
aspheric.
You can use an EMV or a RayOne
or just an aspheric lens, which will preserve what they already have, because I know historically they've already had good depth of field from that.
But would you say that, overall, Darshak, would you say that using a lens that does push the spherical aberration a little bit up or a little bit, what do you prefer? What do you prefer?
Yeah, it's difficult to know, and we've talked about this. Measuring post-ops whole eye spherical aberration and to see how much you move the needle is very, very difficult, because it's just not repeatable enough, not accurate enough to be able to do that necessarily. So it's not, for me, it's more important to make sure that I don't do anything that's going to make them, as we said, toxic therapeutic levels. That's what I'm trying to avoid. But as long as they're within that range, then I'm happy that they're going to have depth of field, and it's not going to be a pure monovision situation. As to whether or not, I've increased it by 0.2 microns of spherical aberration, and they're going to get so much more depth of field of that. But that's very difficult to measure. Yeah. Right. You'd have to do defocus curve probably. You
mentioned the simple tests that we use for depth of field, because people shy away, obviously, from doing full defocus curves because they take so long to do.
Yeah.
And so we simplified this here by just saying, by looking at two things. What is the distance corrected near vision? That's a rough measure of depth of field. And when you have the patient perfectly refracted with their exact plus 0.75 minus 1 or whatever they've got, you then put the R lens in, which is plus 150, and see how much they see through plus 150. So that gives us two indicators of depth of field in very quickly and very simply without spending a lot of time. And looking at what we call the plus 150 vision is really useful. For example, nascent eyes pre-op will generally have 20/60 or 20/80 vision through a plus 150 lens. And post-presbyond, they'll generally have 20/40, 20/50 through the plus 150 lens refracted to Plano. And some patients will have 20/25 through plus 150. It's crazy, but it's not actually on a graph. It's like, oh, if you put this much Q or spherical aberration, you will get that depth of field. It's some kind of neural processing that some people have more and some people have less. Yeah.
But Dan, these are great tests that you and Darshak are suggesting. Simple things to look at. I think we should make a point of clarifying that you're talking about spherical aberration based on the topography at a 6 millimeter zone and the therapeutic range of 0.3 to 0.6. But that doesn't translate to people measuring spherical aberration on something like an eye trace, where 0.4 usually becomes symptomatic. But this is really helpful, but as long as people understand what we're talking about, And this is very easy and straightforward because these are numbers which you've described, which you can pick up on your topographer and use as a guide. But it's different to when we talk about spherical aberration in the sense of a wavefront aberration that we measure, with someone who's got a pupil of 3 or so, where 0.4, they're usually complaining. And when people talk about multifocals and not using them, and they say you shouldn't have a wavefront aberration of more than 0.4 or even less than that. So we don't want people to be confused about that and mix the 0.3 to 0.6 as measured by other methods. But it's very clear. And I love your defocus measure of depth of field. That's also a very simple thing to do.
Very simple.
Okay, do you do that on cataract patients as well? Do you quantify it?
It's obviously a bit harder with cataract patients because they've got reduced visual acuity, but you can still do that. I mean, it still gives you a reasonably good measure, either 20/25 or 20/32, and they're reading, N8, N10. Now,
Yes.
you then have to consider, obviously, are those aberrations coming from the lens itself, which you're going to be removing. So
That's the point.
yeah. So,
But post-surgery, do you do it post-surgery?
We always
yes,
do.
every test, every visit. Yeah.
It's in our EMR. You have to fill that in.
That's so good. Yes. Darshak, quite provoking, I think, using deliberately spherical aberration to improve depth of focus in post-LASIK patients. People are doing lots of presbyopic type lenses of all sorts, including multifocals post-LASIK. And theoretically, anyway, I think the spherical aberration is probably a safer way.
Yeah.
And probably positive spherical aberration is a safer way as well. Because the biggest difference between positive and negative, I mean, they are kind of mirrors of each other, except the way it shifts the focus curve, but also the sensitivity to decentration is much less with positive. And post-LASIK, you've got a corneal ablation, which may not be perfectly centered. Your lens will never be perfectly centered. And if you're using negative spherical aberration to get your additional defocus, you may not be as protected as if you use positive, where your perfect centration of your lens, which you're never going to get anyway, is not as important.
Yeah, and that's true. And also, most of the treatments we're doing are previous, hyperopic ablation is not necessarily as common. So most of the treatments, the cataracts I'm doing, are previous myopic patients. They have positive spherical aberration. I might be using an EMV. But just going back to your point about trifocal lenses and more complicated lenses post laser, we have to also consider the refractive outcome is not 100% with the true KTK, as obviously you're aware, and so these lenses where we're just playing with spherical aberration are much more forgiving. In my experience, somebody might end up plus 0.5 in the distance eye and minus 1.75 or even minus 2 in the near eye, and they're often quite happy with that, or at least they tolerate and they get used to it. Whereas if you end up -1 with the trifocal, that's a problem. You're going to have, so I would think your laser enhancement rate, if you're using those kinds of lenses, is going to be higher. So that's another reason why it's just an easier and safer and more predictable to be using modulation of spherical aberration, whether that's with an EMV or the other direction, is going to be more forgiving and probably have a lower enhancement rate.
I understand. I mean, that's a very good point to make. Dan, you alluded earlier to the confusion that has arisen between the many types of optical principles that are broadly classified either as EDOF or classified as enhanced monofocal. And how are we ever going to get out of that?
Trademark names are used instead of scientific descriptions. And it's very confusing out there.
If you look at I think it's the American National Institute or ANI or NSI, whatever it is, definition of an EDOF being maintaining 2032 with 0.5 dark to defocus, that needs to be updated. And there are other criteria, obviously, but those 4 criteria really need to be updated because there, as Dan says, there's absolutely a distinction between wavefront altering lenses. And if you look at a lot of the data on EMV, it's close to 100% no dysphotopsia. And I'm not getting paid to say that, by the way. That is my experience. We ask patients about vision, night vision, at every single visit. And whether I've used it post laser or without laser, I've never had a patient complain of night vision. And so that needs to be, that enhanced monofocal group needs to have its own distinction from everything else. And whether you want to call it an EDOF or a trifocal, it's causing dysphotopsia. So there's them. I consider them to be a single group. And then enhanced monofocals, if you want to call them that, whereby the dysphotopsia profile is not even the same, it's not even comparable. That's where I would draw the line. I wouldn't draw it at trifocal and EDOF. I would draw it at trifocal EDOF as a single group, and then enhanced monofocal I would consider to be separate.
Darshak, last question to you. Your post-refractive patient, you've chosen and extended the depth of focus. First eye's done, they're on target. Do you use some anisotropia, some level of modest monovision in the second eye?
Yeah, well, predominantly I do bilateral. So I would do both at the same time. There may be some benefit to doing it one at a time, but then because people like to fudge the IOL choice for the second eye, but after laser, I don't think there's a convincing argument for that because there's not a consistent hyperopic and myopic shift that I found. So I don't think that's, so I do both at the same time. And yeah, I always aim for some, as we said earlier, you can't have, it's very unlikely to have complete range of vision using wavefront alteration to have N4. And the types of patients that we have, I mean, it's Harley Street, they're demanding, they're younger because it's central London. So they want N4. Because ultimately, I think if you are N4, maybe N5, your day-to-day outside the house, inside the house, you might need readers, but outside the house, when you're going out and about, you're not going to need readers. You're going to be reader free. So I tend to aim for at least -1.5. If they've got a lot of depth of field, I might do 1.25. But as we do with presbyon, 1.5 is the default. And by and large, they get N4 with that.
They'll read very well. I usually use 1.25, but let's not fight about a quarter, doctor.
Yeah.
Look, I think let's come to a conclusion.
I think the point, just to summarize, is that don't be afraid of using the EMV or trying to manipulate spherical aberration with good pre-op assessment, obviously management of dry eye, good biometry, keratometry, Barrett tree K, and all the things that come with it, trying to get an accurate outcome. You're going to be very close to target. However, it is a form of monovision, so you need to consider that. I say to patients 10 to 20% enhancement rate. It's probably less than 10%, but I do prep them that we might need to do laser on top. So I think having that in your armamentarium or somebody that you can refer to be able to do that is very useful.
Well, thank you both. I mean, it's a fascinating field. The conversation, I'm sure, will continue, but I think both of you have really shed light on some of the issues at stake and given us some very practical, useful tips on how to assess patients and how to provide more than just a monofocal lens and give these patients who expect they're used to being able to be totally spectacle free and giving them a chance to maintain that after they've had their cataract or their lens removed. So thank you very much.
Thank you for having us.
Thank you. Thank you.